Thank you. And Senator Merkley, thank you so much for joining us. Now, I know we're here to discuss the future of Medicare, but it's the concept of Medicare for all that's grabbing headlines right now. And I did something unusual this week that I don't usually do before I moderate. I posted on Facebook. I said, hey, I'm going to be leading a discussion about this. What do you guys think? My Facebook page blew up. I mean, people are so passionate about their health care. And you've been supporting the concept of Medicare for all really from the start. So why?
Well, I'll tell you, I do a lot of town halls.
Okay.
And so out over Oregon, 36 a year, one on average every 10 days. People are so frustrated by the cost of the system and the complexity of the system. They're looking towards having a seamless, simple plan where they're cared for, their loved ones cared for if they're hurt or injured just by virtue of living in the United States.
So if Medicare for all were passed, everyone would be on it? I mean, senators, congressmen?
Everyone would be yes.
Okay.
Yeah. Yes.
Now, the Congressional Budget Office, however, last week came out.
Think about this. I mean, right now, if you're on Oregon Health Plan, which is our Medicaid, and you earn a little bit more money, you're thrown off. Right now, if you have private insurance and your company then says this year we're not going to cover your kids, you have to figure out how to do that. They say they're not going to cover your spouse. You transition between jobs, it changes. It is the most complex and frustrating system to be found in the developed world, and the most expensive. We can do a lot better.
But the Congressional Budget Office looked at it. They didn't give a figure for it, but last week they came out and they had really a mixed analysis of it. I mean, they said that certainly there could be savings realized by consolidating the administrative costs, and they said Americans' health care could improve, but they also said we could have longer wait times, we could have reduced access, and they said there certainly could be more federal spending needed. So what do you think about that?
Well, I don't think there was anything shocking or different in their commentary. They're saying, hey, there's questions to be answered, and if you move your costs from the private sphere to the public sphere, the public sphere has to pay more, but the total costs drop enormously. And that's the main issue. We have the largest percent of our GDP in the developed world, and we have lower health outcomes. So if everyone else is doing better than we are, we need to pay attention to how ideas that other countries have pursued.
So you say costs would drop immensely. Now, I've heard predictions that this would cost over a 10-year period on the lower end of an additional $32 trillion over that 10-year period.
Well, it's not in addition to it's not an increase in the healthcare costs. It's a transition from private bucket to a public bucket. So our country as a whole pays less. And that's very important to keep accentuating that because otherwise it's a complete misunderstanding of what occurs. And you think about the power to cut costs throughout the system if you have an administrative cost that only a few percent rather than 20%, or if you negotiate the price of drugs, which is a complete failure in the current system. And then we go back to the fact that everyone's covered, so your uncompensated care that goes to rural hospitals, clinics throughout, and urban also drops enormously. So there's all kinds of advantages to having a better system.
Now, as a way of getting to the better system, I know last week you reintroduced your act, the Choose Medicare Act, you and your co-sponsors. Talk to us about what that involves and how is that different from Medicare for All?
Well, it's an on-ramp. Inside Medicare for All, currently inside the main bill, you have an on-ramp that is decreasing ages. And Kirsten Gillibrand has added into that a buy-in. This is another way of providing a public option buy-in as a way to become familiar with the concept and to dramatically cut costs. We have a public option like this in workplace healthcare in Oregon. It's called State Accident Insurance Fund. People don't even realize it's a public option, but it cut the cost of workers' compensation in half when it was introduced. Rhode Island looked around the country and said, where's the best plan in the country? They adopted the Oregon plan. It cut the costs in Rhode Island in half.
So you think that could work on a nationwide level then?
Oh, absolutely. Yeah, absolutely. And because initially people are taking the funding that they spend on the exchange anyway, and they're buying a Medicare plan, and so same tax credits, if you will. same personal spending, and companies under our plan, and Chris Murphy was my partner in putting this together. So under our plan, companies can buy a Medicare plan as well, which greatly increases the number of folks who are covered. And then once you have that, you can carry that with you going forward, so you don't have to worry about transition from one company to another. So it takes away the notion that in the beginning, anyone who's afraid of Medicare would be forced to leave the healthcare plan they have in adopting Medicare.
What kind of reaction are you getting to your plan? Who is supporting it? Have any Republicans signed on?
No Republicans have signed off. No, I mean, once you say you're going to negotiate the price of drugs, there's no Republicans to sign on to it because they're not willing to take on the drug companies that are gouging the American public. And I can tell you this, the two things that resonate for people are the complexity of our current system. People do not want to have to worry about it and renegotiate it throughout their entire lifetime from one place to another, and the gouging that takes place. Now, we fund, as taxpayers, the basic research is a foundation for a lot of the drugs that are developed. It's not Canada funding, it's not Europe funding, it's not Japan funding it. We should get the best prices on drugs, not the worst prices.
On the note of drug pricing, the HHS Secretary just this morning made an announcement finalizing a federal rule, this is hot off the presses, folks, requiring manufacturers to disclose drug prices in their TV ads. And Secretary Azar said that requiring this is, quote, the single most significant step any administration has taken toward a simple commitment. American patients deserve to know the prices of the health care they receive. So how significant is this?
Well, it's not very significant. For one, it's going to be very confusing because people are going to say, is that the price I pay? Because don't I pay just a fraction of the drug price because I have insurance? Or is this what the pharmacy benefit manager pays before it gets to me? Is this what I pay under my Medicare, or is it under some other insurance? It's going to be extremely confusing. Here's what's going on. The president campaigned on taking on the high price of drugs. It's really a big deal to Americans. But then he bailed out on actually doing it. So he's looking for some other ways to do some little thing he can publicize to say I took some action. And so this may, I don't know if this will even be at all helpful. It may just be more confusing than helpful. Well, we'll have to see. But it's not about serious reform in the system.
Well, what about the administration's proposal to end rebates to pharmacy benefit managers?
Yeah, that is not about serious reform either, because he's not taking on the fundamental cost that's being charged for the drugs. What he's doing is squeezing the balloon here, and then the costs come out elsewhere. And in this case, there's been reports that this would actually increase the costs that Medicare would experience rather than decrease them.
So you think the best way to proceed is just give Medicare the ability to outright negotiate prices?
Well,
and how do we achieve that?
I think that, well, it's a line in a bill. It's a beautiful thing. It'd make a huge difference. But I believe we should be able to negotiate the price of drugs not just for people over 65, but for everyone. So my reference pricing bill says, look, we're going to compare to the median. We're going to take the median price of Canada, the largest 11 European nations, and throw in Japan as well, and you can't charge more. That's the ceiling. So if a drug company says, well, you know, I've been gouging Americans and now I won't be able to do that anymore, well, if they want the same revenues, they're going to have to raise their prices in these other countries as well. So they can get the same revenue, but not by making us the victims of their pricing.
And what support do you have for that measure?
I'll tell you, this is universally supported. You go to town halls, you ask people about ending this gouging, why we pay more than the Europeans, Canadians. It is, everyone supports it. Most of my
Congress,
counties.
I guess what I'm saying
Oh,
is
in Congress.
Republicans and people you need to
well,
pass
that's
it.
another question.
I mean, aspirationally, it's a lovely idea.
Well, it is one of these issues that reflects the corruption in our system. And that corruption is the massive funding of campaigns by drug companies. And so in Congress, people are afraid to stand up and take a stand on this, just like the president's afraid to stand up and take a stand. Now, last year, for a moment, the president said, I want to do a reference pricing bill. Well, I have a reference pricing bill, what I've just described. It's ready to go. I invite President Trump to actually get serious about taking on an issue and join me in this effort.
Let's talk about the solvency of Medicare, because Medicare trustees say the program may become insolvent within 7 years. How worried are you about that, and what solutions do you see, if any?
Yeah, the trust fund, unlike in Social Security, doesn't cover all of the costs, but it is a 7-year projection. There are some things that could save a great deal of money, one of which we've just been talking about, which is being able to negotiate the price of drugs in the system. Another is to move away from fee-for-service. Fee-for-service incentivizes waste. If I say to you, everything you spend money on, you will get compensated plus a profit margin, you're going to spend money on a lot of things. And so going to value-based care, we do this in Oregon's Medicaid program, the Oregon Health Plan. We have these they're referred to as CCOs, Coordinated Care Organizations, and it greatly delivers more health care for less cost. So there are reforms within Medicare on drugs and on the provision of services that can cut costs, and I think that's probably important reforms to pursue.
Before we go to questions from the audience, what about what some people suggest as a cost savings measure to boost the eligibility age to 67 from 65, just as Social Security has for full benefits?
Well, that's a terrible idea. Well, we'll simply going to go to a little feedback. Let's see, how many people would like to wait till age 67 to be on Medicare? I'm asking the audience here.
I don't see a single
I don't see any hands
Okay.
being raised.
But if it meant the program was solvent for 10 more years?
Listen, you have this time gap that has to be paid for in some way. And that's why it's not a solution to say, well, this system over here is going to start at age 67.
Even if
so
we're
now
living
we'll have a more
longer,
expensive private care system that will actually increase costs overall before that age.
Okay. Well, let's go to the audience. I'm sure we have a lot of questions. And if you would, please tell us who you are and who you're with.
I'm Dr. Caroline Poplin. I'm a primary care physician. My question is, when you cost out Medicare in the future for Medicare for All, are you assuming that employers are going to continue to pay a Medicare tax just like they do for Social Security? Medicare is actually part of Social Security, and I'm afraid that people are assuming, well, once we go to Medicare for All, the employers are off the hook. They shouldn't be.
Thank you.
No, that structure stays the same.
Well, that's a short
So
answer.
employers still, yes, contribute.
Okay, so
Under Medicare for All, yes.
we had another question right here.
Hi, my name is Marina K. Ayavon. I'm a consultant with Avalere Health. Thank you so much for the discussion. So I think a lot of people are a little hesitant to fully support Medicare for All because they don't understand, because I think they are having a hard time understanding the reality of getting rid of an entire health insurance industry, especially since it's such a large industry. So do you have some sort of example or reference point of a government program essentially eliminating an industry as Medicare for All would eliminate private health insurance?
Well, this concern that you're expressing of how do we get from here to here, because they're so different, how do you make a transition, is why there's so many different ideas being put forward. My public option, Choose Medicare, is one way to make that transition, which individuals make it and companies make that transition. And we've seen that roadmap before, just as we've seen with the public option in Oregon. So that's a well-established path. Another strategy is to lower the age, and that's what's in the existing Medicare for All. First year 55, then 45, then 35. We have 3 or 4 other bills that are laid out that are slightly different by different members of the Senate, and this is really good because rather than wait for the moment when there is political momentum to act and then say, well, let's study this and try to figure out something, it's important to have this conversation now, which is why I so much appreciate this forum and other forums like it to wrestle with the ideas and the alternatives. So I think that your point is one that has to be wrestled with. What is the on-ramp to get there? And I think there are many bills trying to address that question.
All right, another question right here.
Hi, Senator Ryan Hill from Cambia Health Solutions, which is headquartered in Portland. So we thank you for your support over the years. My question is about the fraud, waste, and abuse numbers in traditional Medicare. So we're seeing that over $70 billion a year is cited as fraud, waste, and abuse in the traditional fee-for-service Medicare program, aside from what's in Medicare Advantage. Out of all the bills and ideas that you have, do you have any idea of how to tackle the current fraud, waste, and abuse, and given that it may be expanded if there are more people in the Medicare program? Just like your thoughts on that.
Yes, well, I'm glad you raised it, because it's so frustrating when you have a setting in which some providers are proceeding to charge lots of things because of partly this fee-for-service structure that I was talking about, that invitation to fraud. So having a robust unit within Medicare that watches the billings across the country and says, hey, this pattern looks suspicious, and then investigates it on an aggressive fashion, not only finds that type of basically crime within the system, but discourages and prevents it because people will know they're going to get caught. So we have a lot of computerized data that can be studied to see those patterns, and we need to do so in a much more aggressive fashion.
All right, another question. We have one here in the front.
Hi, good morning. My name is Josh LaRosa. I'm Policy Associate with Win Health Group. Thank you so much for your time this morning and your comments. I was just curious, I appreciate the comments you made about value-based care and how that is a potential solution to curbing costs in Medicare. I was wondering how Medicare for All plans, or particularly the Choose Medicare Act, would create additional on-ramps for value-based purchasing, and if you see any opportunities for that with those types of legislation.
Yes, absolutely. So there is, under our bill, Chris Murphy's and my bill, it doesn't immediately make just a sudden transition, but it creates a pathway for experimenting with value-based and then taking those best practices. It is, I think, a very important piece of the puzzle. We've seen it exercised elsewhere, where it's not just some theory without any evidence on the ground. The evidence is there. And so let's take that evidence, those best practices, evidence-based practices, value-based, and kind of ease the Medicare system into that vision.
All right, more questions? Anyone in the back? We've been favoring the front of the room. I know you have thoughts back there. Here we go.
Good morning. I'm Hannah Lynch from Bio. Thank you for being here and answering questions. The administration put out the IPI model earlier this year, and there's been some discussion that maybe they won't follow through with that, and there could be potential for Medicare reforms on the Hill instead. So what are your thoughts on the IPI and the probability that that will actually move forward, or should the Hill take action on that?
Help me with the initials you're saying. I couldn't quite catch that.
So it's the International Pricing Index model. So it's the Trump administration's sort of version of reference-based pricing.
They have a pilot project. They have a pilot project on a very small piece. It has not gone into effect yet. I don't know all the details of it, but I understand it will affect it's a very small effort is what I understand, but I can't give you any more details than that. A little tiny pilot project is another way for the administration to say, see, we're doing something, without really doing something.
All right, more questions? Do you have any in the back? Well, Senator, in wrapping up, if you could, what is one thing that you think in this session of Congress is really possible to be passed in a bipartisan manner that would help Medicare as it exists today?
No, what we have seen is very little bipartisan cooperation. There's been constant sabotage of the system, and we're having difficulty getting our colleagues across the aisle even to stand up to the sabotage. And when I'm speaking about that, I'm speaking mostly about the exchanges. For example, cutting the open period, getting rid of the facilitators or cutting the facilitators, shutting down the exchange on Sundays, damaging the reinsurance strategy that invites more companies to participate and create more competition. So in the context of that, there's very little I guess, energy that I'm hearing from my colleagues across the aisle to buck the administration and actually try to improve healthcare. There's
for
some
60 million Americans
I know.
who rely on
So there's some exceptions to that, and Lamar Alexander has said he wants to work to take on some of the costs in the system, find cost savings. But so I hope that those hints can be translated into actual reforms. But if you're going to reform a system, you have to be willing to take on very powerful interests. And that is something that we don't have a majority of the members of Congress willing to do that. And I must say that my frustration is enormous on this. When you have an issue that 90% of Americans say, go and act and take this on, like the price gouging on drugs, and we can't summon legislative ability to do it, it shows how deeply dysfunctional we have come. And I know I mentioned it before, I'm going to mention it again. The gerrymandering, the voter suppression, the dark money corrupting our system is really a problem for solving everything else we want to undertake. And so the bill that was just passed in the House, H.R. 1, and the bill that Tom Udall and I have in the Senate, the For the People Act, that takes on those issues, would provide the foundation for being able to move forward effectively on healthcare and on housing and on education and on infrastructure and on the Equality Act and on taking on carbon pollution. I live in a blue-collar community. That community is so different than some of the communities where I have raised money when I have been running for office. And I remember specifically the first time I ran for the Senate being in New York and meeting with an individual who said, I don't understand why you're talking about health care. Everybody I know has health care. Well, that may be true if you're a Wall Street executive. But in my blue-collar community, people are so wrestling and worried about healthcare. We still, even with insurance, when you're paying 20 or 30% of the bill, you can go bankrupt very, very quickly. We are still the only democracy, or the only developed country where we have rampant bankruptcies due to medical costs. So this is ripe for reform, and any one bill may not be the perfect answer, because maybe there's no perfect answer, but we know the direction to move in, to move to value-based pricing, to move towards taking on the price gouging on drugs, to move towards universal coverage, and we need to summon the political courage to do it.
Senator Merkley, thank you so much for sharing your ideas and your passion.
Thank you
Appreciate
all
it.
for being part of this. Thank you.